Okay, we're now live.
Thank you. Thank you very much. Okay, I'll make it 6 o'clock. So welcome to the Adult Health and Social Care Scrutiny Board on Thursday, the 10th of February 2022. Glad to say it's getting a bit lighter, staying a bit lighter for a bit longer, so it does make you feel a little bit better, even though it's absolutely freezing. So let's get on to the main items of the agenda tonight. So substitutes nominated for this meeting, and apologies for absence. I don't think there were any substitutes, and we've had no apologies, is my understanding.
No substitutes. All members are present and correct, Chair.
Fabulous, that's super. Well, welcome everybody. Welcome guests as well. So members' interest, to remind members to declare their interest at the relevant time. So thank you for that. Item number 3, admissions to the public. It's not recommended that the public be excluded from the meeting for the consideration of the item on the business of this agenda. Anyone viewing us on YouTube, you're most welcome, and hope you enjoy the discussions. So we don't have any minutes from the last meeting because it was so short since the last meeting, and even though Diane's a superstar, she can't whiz out minutes as quickly as that. So we'll expect to see those at the next meeting. So we've changed the agenda around slightly. So item number 4 now is NHS priorities and operational planning guidance 2022 and 2023. Welcome Neil, welcome Anna. It's always nice to have you here, Anna. So Neil, do you want to lead on this?
Yeah, thank you, Chair. So I'll just sort of give a brief summary of the paper that's been there, and clearly people will be aware of the announcement this week of the elective recovery, so I'll touch on that a bit as well and bring Anna in to sort of help. So within the paper, the guidance that was issued just before Christmas comes up with 10 priorities, which is around workforce, responding to COVID, elective recovery, emergency care, timely access to primary care, mental health services, population health management, ill health and health inequalities, digital technologies and use of resources, and the ICB collective system working. I suppose the key point, which is in section J, is people be aware that the integrated care boards will now be set up from the 1st of July, subject to legislation being passed rather than from the 1st of April. People will have seen numerous recruitments going on, and clearly Rob Webster is appointed as Chief Exec Designate and Cathy Elliott as the Chair Designate, and clearly structures being put in place to mobilise that going forward. So there are 10 items there. There are brief summaries within each one of those, but I just wanted to touch on a couple in a little bit more detail. So this week, there's been a plan for tackling the COVID-19 backlog of elective care. Some of the priorities that have come out in that aren't a lot different to what was in the original planning guidance that came out in December. However, what it does help is manage expectations of recognising how long it will actually get to get our waiting list back to pre-COVID levels. So a lot of work has gone on, particularly in the last 12, 18 months, which I'm sure Anna will be able to touch upon. And some of the priorities around elective and particularly cancer care, we are actually performing above a lot of our peers in this moment in time. So the 62-day wait for cancer care, we're in the high 90% for achieving that already. And that has been a priority for us as a place over the last sort of 12 months as we go forward. But there's clearly a lot to be done, and the elective recovery does rely on a certain amount of workforce, and the plan recognises the pressures that the health and social care workforce has been under over the last 2 years. Hence, it manages the expectations out to 2025 for us to get back to similar levels. I suppose one thing to elaborate on, particularly around the elective care side of things, is there will be significant investment, particularly in diagnostics and out of hospital diagnostics, of which our partners across West Yorkshire have been working upon that for some time, and to sort of separate elective and, I suppose, emergency care workforces to enable people to be more productive. Some of these take time. Workforces, I think the paper alludes to, doesn't grow on trees, and it can take 12 years to train a consultant and 7 years for a nurse. So they are nationally expediting the international overseas recruitment, and they're creating a significant amount of additional roles and new roles, which a lot of hospitals and primary care and mental health providers are taking advantage of. So there's a lot of work to do in a short space of time, but to recognise that within Calderdale, we are in a good place with regards to our elective recovery, our urgent care responses, our access to primary care, and our continued investment in primary care, and the continued investment in the additional roles which we are starting to see benefit of with social care prescribers, but also the investment in mental health standards and the priorities around children, which we've seen and reported to the Children's Scrutiny over the last few months as it is. So sorry if that's a bit of a whistle stop, but there is quite a lot in there, and I wanted you to be open to questions that hopefully we'll be able to answer. There's quite a lot to go at. Anna, is there anything else to add from a hospital perspective?
No, I just think you've covered that really well, Neil. I just reiterate the comment that you made, that we have a lot to do, but we have during recent months been able to make progress around our elective recovery. So we have increased our activity. We know that we definitely want to develop our plans to be able to address all of the priority areas. We take this very seriously. I think the fact that we've been able to maintain our elective activity during a particularly difficult period during the recent wave of the pandemic and during the winter period as well means that it gives us optimism that as we start to see hopefully a reduction in the numbers of inpatients with COVID, that will help us again around our capacity. It's currently a very key area of our focused work and planning to develop our clear trajectories for our way to address the backlog. Now, happy to take questions. I would just comment, I think colleagues know I'm not the operational lead, so there may be questions you'll ask me I can't answer, but I will certainly take those away and be able to come back to you with fuller answers if I'm not able to respond to them this evening.
Excellent, as you always do, Anna, so thank you for that. Right, I've got Councillor Hutchinson first of all, please.
Thank you. Not surprisingly, I've got a couple of questions, if that's all right, Chair.
Absolutely, yeah.
First one, at the risk of sounding like a stuck record, I've been trying to explore the workforce plans across West Yorkshire for over 3 years, and it's been like banging my head against a brick wall. There are no plans that anyone is willing to discuss with us. So my key, an understanding of the gaps that exist in the workforce was described back in 2018 and then conveniently shelved. And no one has been able to provide the Joint Scrutiny Board for West Yorkshire with a clear understanding of what the workforce gaps are and whether any measures are being taken to actually deal with them. So my question there is, whose responsibility is it to tackle the gaps in substantive staffing at primary amongst GPs, mental health, acute care, community services for a start, and what can be done at local place level, Calderdale and trust level, but principally what can we do to make sure, the West Yorkshire integrated care system will cover a population of 2 million people. It's big enough to have a local workforce plan to develop the workforce that we need, rather than seeing the provision of our medical services continuing to shrink. So that's my first question. So I'll stop there. And
indeed, I'm looking towards Anna. Might be able to answer that, I'm hoping. Neil,
first, Anna. So I think we recognise across West Yorkshire this is a hugely complex area. covering multiple members of providers of different sizes. And I think that's been recognised in the structure that the West Yorkshire ICB is putting in place, and is looking to appoint a director of people, which predominantly will, have a big remit of bringing the work that's done in places and providers together, so that we can have that coherent plan. I think all individual organisations have plans, and Anna will be, I'm sure, able to talk about CHFT plans. And we have, over the last couple of years, created the environment for providers to talk to each other, to understand what the needs and the gaps are, so you're not robbing Peter to pay Paul. So particularly with the primary care investment and the additional roles, we have been encouraging, and we've seen success in our providers working in a collaborative manner, because we recognise there are finite resources in physios, in occupational health, in GPs, in all physicians. So those conversations are now starting to take place. And you've got to remember that they didn't used to take place. Providers used to be their own organisations and have their own responsibilities. There's never been a remit for you to work at scale, to work collaboratively, and they're now starting to see fruition. So the work that the West Yorkshire Association of Acute Trust does, mental health providers, and our primary care are all starting to have those collaborative conversations to ensure that when we have the conversations with Health Education England about the number of GPs, the number of nurses that are needed, the true number is submitted to Treasury to fund those places and the university places available. So it's hugely complex, but I think that has been recognised as a priority in the West Yorkshire strategy.
Thank you, Neil. On your second question, Councillor Hutchinson.
Sorry, I would like to point out that it didn't always used to be that organisations didn't speak to one another. Before the purchaser-provider split, before the fragmentation of the National Health Service into numerous freestanding organisations, there was a national responsibility to produce the workforce that was required at national level. That has been lost in recent years. I would like to know where we are on track with actually recruiting. We found out a couple of months ago that Calderdale has one of the lowest levels of GPs per head of population of anywhere in Yorkshire, apart from possibly Hull. And so we're badly provided with GPs numerically. I would like to know what we're doing locally to redress that problem, and whether we've had any success, what the figures of GPs are actually doing within Calderdale, whether they're going up, going down, or in terms of full-time equivalents.
Thank you for that. Anna, do you want to come in on that? Because I know you're going to comment earlier.
So in terms of, I think Councillor Hutchinson's question there was particularly around GPs and primary care workforce, where I think probably Neil would be able to respond more fully to than I would. But I did have some comments just around the overall local response around workforce planning and the question that you raised prior to that around what are we doing. Neil referenced the work across West Yorkshire and on a people plan. So there's definitely work going on at West Yorkshire level. But one of the other comments I would make, you referenced that the need for organisations to work together. And certainly what we have across the West Yorkshire Association of Acute Trusts is an approach around providing mutual aid, working together around recruitment to address where there may be strengths or weaknesses in workforce levels. That's a really key feature of our work, working across the hospital providers. I think the other big emphasis, particularly over the last 18 months coming out of the pandemic, is about making sure we're doing everything we can to support our existing workforce and to retain that for our local population. So big emphasis around well-being, around working patterns, and about providing opportunities for development locally. It has been a big emphasis. And also, you may know we've been recently very successful through international recruitment schemes that is helping to fill some of our very important roles in nursing roles locally as well. So there is a lot of activity being undertaken. So I know that only partly answers your question, Councillor Hutchinson.
Neil, do you want to come in on the other part?
Yeah, so on the primary care thing, I think we've touched on this briefly in the community paper before, in that the number of GPs per head is just one barometer of how good or how successful or how effective your primary care is. It's not the definitive thing. So we have been under that barometer for a number of years, been under-doctored, and we've done numerous things to attract them with APMS contracts and unfortunately not been successful. I think with the advent of our primary care networks and this more collaborative working, we are having different workforce conversations. As a place, we're one of the highest and best for GP training, but after that GP training, our retention is quite actually poor. So what we are trying to do is work with our practices, who are independent organisations, around their structures to be able to attract and retain some of those people. But also, we've got some fairly innovative practices that use other roles and other specialties to see it. So we have one practice within Calderdale, which is nurse-led. So you wouldn't even know you're not seeing a GP. So there are other skills and there are other ways to meet patients' needs, and that's what we've been good at in Calderdale over the years. And we need to build on that initiative and work with it and attract and train GPs as well.
Thank you, Neil. Colin, I think you might have another point to make as well.
Yeah, thank you. I did want to explore what's going on in terms of elective diagnostics. I mean, I don't think we should be referring to this as the COVID backlog. With more than 4 million people on waiting lists before COVID occurred, the NHS had abandoned its drive to adhere to the 18-week referral to treatment time because it hadn't been met for so many years. But certainly it's gone up from over 4 million to now 6 million and rising. So that's for sure. But in terms of actually defining the problems that people have, what, you know, trying to establish a diagnosis, what is happening in Calderdale in terms of increasing diagnostic capacity?
Who would like to lead on that? Anna? Yeah, cool.
I can answer that. You may be aware that in terms of diagnostic pathways, we have performed well in terms of the 6-week access provision to access to diagnostic services, but we do have some challenges. And addressing that, we are currently installing a new, for example, MR scanners to increase our capacity. We're also working with the West Yorkshire ICS. You've probably read around the intent to establish community-based diagnostic services. So we're actively working with partners across West Yorkshire to develop our proposals for that. And some of the announcements earlier this week and previously have been about the availability for investment into community-based diagnostics to improve that access. So there's a raft of work being undertaken currently.
Thank you. Councillor Megan Swift.
Thank you, Chair. Just put a sweet in. Right. A couple of questions in case we don't get round everybody. Why is the CCG taking so much longer than, I don't mean CCG itself, I mean CCG and the other partners. Why is it taking so much longer? We've been working on April for as long as I can remember, and I doubt whether it's anything locally that's stopping it, but I'd like to know what is. Do you want them all at once?
Just pause on that one. Neil, do you want to come in on that?
Sorry, Councillor Swift. What's the question there about April? Do you mean the closure of CCGs or?
Yeah.
So we are guided by national legislation being passed. So this isn't a local determination. So this requires Parliament to pass the Act to dissolve and create new NHS organisations. So we are guided by their timetable. Clearly, the local structures that we're wanting to put in place in the West Yorkshire structure, we were working towards April, and we'll hopefully have shadow arrangements in place between now and June. So we are tied to the national legislative process. So it's not a local delay.
I said I didn't think it was. Yeah, recruitment from abroad. I thought we were stuck on this because the government had said people had got to earn so much money, and some of the nurse-led things aren't the amount of money that was said. Now, is that still the case, or is it different now?
Neil, Anna, which, yeah.
I'm sorry, I don't know the answer to that question. I'm not close to the issue. Again, I'm happy to try and find out more information.
Cool. Thank you, Anna. Yeah, thanks. Thank you.
I don't know answer either, Anna, so you're not by yourself. Right, couple more and then I'm done, honest. Can I say something good? Can I say to Neil or Anna, whoever said it, that unfortunately my family had use of cancer care during the pandemic, and I have to say they were brilliant. We couldn't see that they slipped at all. I know it depends when you go and what, you know, but it was absolutely brilliant. So I'm not picking fault.
And something else, you have another point as well, Megan?
Yeah, but I'll leave it, I think.
Oh, okay, right. Okay, so in that case, Councillor Barnes.
Thank you, Chair. A couple of things. I've got 2 points. Firstly, I think there's some notable omissions in here. There's no reference at all to oral health at all in the whole of this report in the 10 points. So I think as well, it's great to see that we're improving mental health services for people with learning disabilities and or autistic, but there's no reference to mental health services in general. So I think there's a number of omissions, and it would be interesting to see how these are planned to be looked at locally. And the second point, these are some great goals, can't fault them. Where's the roadmap? What roadmap do we have to achieve these? So where do we stand at the moment? For example, great to hear on cancer, but where are we in regard to handover delays between ambulance and hospitals? Or where are we in relation to eliminating waste of over 104 weeks as a priority by March 2022, which I think is in 2 weeks' time. So where's the roadmap for this? And can we have a sight of that roadmap? And in particular, can we have an RAG status, red, amber, green status against those, just to see where we are and how we are progressing against them? Thank you, Chair.
Thank you, Councillor Barnes. Anna?
I just think in terms of the question around milestones and against those national goals and reflecting where are we now and the trajectory to reach those goals and targets, that's the work that's being undertaken at this time. Those plans will be brought together at ICS level, but locally ahead of that during the period up to the end of April, and they will be
sorry, just
available.
Come in. You're working on them. This was issued in December, and one of the targets is March.
So some of those targets referenced in the documents that you're referring to have been updated in some of the announcements this week. There is a bit of fluidity around the national goals and some refreshment of that's actually happened this week, which is why we're continuing to work on those goals. So there is information available. We do publish information in our public reports that we can share, but the definitive, how are we going to reach the particular goals around the national plan, annual plan, that will be published in April.
Neil, do you have anything else to add to that?
Just to sort of carry on from what Anna says. So yes, so there was a big caveat in the December things around particularly elective care, and hence the announcement this week. We are and we will be looking for the plan and the monitoring of this to be done through the local subcommittee of the ICB. So it's a place-based response rather than just a CCG or a provider response. And we will be benchmarking where we are against all those already, and they'll be part of our regular performance monitoring as we transition from CCGs to place-based committees.
Chair, would it be possible to make a recommendation that we see sight of that and it's brought in front of this committee and we have the ability to look at it and analyse it at a future date?
More than happy to put on that onto the agenda, the recommendation. Yeah, absolutely.
Thank you, Chair. Thank you, Chair.
Thank you. So, Councillor Kingston, please.
Thank you very much, and thank you to Mike, because you asked some of the stuff that was concerning me. I did want, though, to ask about virtual wards. I'd like a bit more explanation about what a virtual ward looks like. Is a virtual ward, and by my reckoning, according to this recommendation, we should be setting up between 80 to 100 virtual wards in Calderdale. So I wondered how you plan to go about doing so. And then just if you could indicate to me, what's the primary reason for virtual wards? Because I went online and Googled it, and the answers that I got made it look like it was more than anything a cost-cutting exercise. I hope that's not the case. I hope it's about improving care, not just cutting costs.
Thank you, Anna. Do you want to come in on that? You're certainly nodding your head as though you got the.
I can come in on that, Chair.
Oh, thanks, Neil.
Go on, Anna, you go first.
No, Neil, go ahead.
So I think in the initial guidance, there was a bit of a typo about the number of wards. So where you read 80 to 100 wards, that should mean to an 80 to 100 bed stroke people. We currently have between 50 and 80 people that work in that way already. And by virtual, it's a service that our community teams and working with social care, community service and GPs have been working on for about 12 months. And it's to enable people to be cared for in their own home or their place of residence away from hospital. So it's a multidisciplinary team approach, and it's to help reduce unnecessary hospital admissions. There's been a number of reports over the years about when people do get into a hospital bed, they deteriorate. So this is about taking action to either discharge them or avoid them going to a hospital bed. So it is not about cost cutting. It's about providing the best care where possible in a multidisciplinary approach in their place of residence.
Thank you, Neil. Anna, do you want to add anything to that? Okay, thanks for that.
No, that's great. That's the answer I wanted. Thank you very much.
Excellent. Good question as well. Thank you for that. Councillor Durans.
Thank you, Chair. I'll just have to open up my notes. Sorry. Part of my question's been answered, but in section F about improving mental health services for people with learning disability and autistic people, is that including the diagnostic pathway? Because it doesn't make it clear whether it is improving the diagnostic pathway for adults in that area and young people. And the second one was in regarding the management around ill health inequalities and redesigning the pathways. I just wondered if that was in all areas around, I'm considering like dental care and things like that, or is it specifically around primary care? So yeah, that's it. Thank you.
Neil, thank you, Neil.
Yeah, thank you. So for that first one, you should read all ages, and the access to those diagnostics is a priority for us in Calderdale. We've done a lot of work, particularly around children, and we are doing a lot of work at the moment around adults to ensure that we have better access to that diagnostic. So we do prioritise all ages here in Calderdale. And that second one, the approach we're taking in Calderdale is health inequalities to all sort of health and social care. So Deb's and partners leads on a number of areas where we're looking at health inequalities and how we can bridge those, not just in primary care. We would love to look at things like dentistry and oral care, but that is unfortunately out of our remit at this moment in time. That's NHS England, but we continue to work with them to understand what the pressures are. But there has been a lot of work looking at how we can bridge those health inequalities, looking at what access are for different services and how we can bridge those gaps over the next 12 months to 18 months. But a lot of work going across partnership working to understand the issues and to improve those. And it is very much a key strategy within the health and wellbeing strategy that the Health and Wellbeing Board monitors.
Thanks. Thank you, Neil. Councillor Hutchinson.
Thank you, Chair. Can we look at section 2I on the final page of the report? It says that there's going to be changes to the fair share allocations. Is Calderdale consuming more or less financial resources than its relative need? So is the funding of Calderdale going to go down or go up or stay the same? And the other thing that I was surprised at, where it says written contracts between commissioning and all providers will be required by the start of the financial year. I thought that written contracts were the normal way of commissioning services. Am I wrong?
Neil, do you want to come back? Yeah, thank you.
Yeah, on the first thing, we're still working through what this means around allocations. So allocations are moving from CCG level to the ICB level, so they're going to be on a West Yorkshire basis. And they haven't published the sort of guidance of whether people are over or underfunded. If we work on our historic, we weren't overfunded and we weren't overfunded. We were just about right in our direction of travel for our main commissioning. For primary care, we were slightly underfunded and we were getting increased levels of investment to bring us up to sort of that. So we've got to work all through that as an ICB, and that'll be part of the plans that we bring back later on as to what would be the share out to Calderdale. We are expecting it to be fairly similar to the levels we've got now and the pre-published levels of increase. There is a bit about they are looking to sort of smooth things and ensure that appropriate places, and there is a bigger influence on deprivation and health inequalities in the new formulas that they're proposing. But we'll report that once we know more. But at this moment in time, that's what we're working through and hope to have a better idea when we present our sort of final plan in April.
Thank you for that.
Sorry, Colin, what was your other question?
Yeah, it was about written contracts being required between commissioners and providers. Conjures up the idea of people sealing these with a handshake or an elbow.
No. So across the NHS, and not particularly in our area, we've got and had very good relationships with Calderdale and Huddersfield Trust, with our aligned incentive contract and with our mental health providers. There is always an annual requirement for contract values to be agreed before the start of the year. And there are a number of areas where that doesn't always happen. And we have arbitration processes. I can reassure you we haven't been in those realms for a number of years because of the relationships we've got between organisations. But that is a bit of a warning shot to other areas and other providers.
Okay, thanks for the clarification.
Thank you, Neil. Councillor Kingston.
Thank you, Chair. Just the section again on mental health. I notice it says there's like no specific targets around waiting times in this section. And I just wondered, and I know that there are incredible lengths of wait for people to get, for example, talking therapies. And I wondered, do we have targets locally, length of time that people should be allowed to wait to access talking service therapies or mental health services in general?
So for IAP services, which is the talking therapies, we do have targets around access and recovery, and we report those in our performance reporting through the CCG, and we do actually have quite favourable performance in that. However, in more specialist areas, there are longer waiting lists. However, there aren't any national particular targets for that, but we do monitor it and work with partners to try and improve that as much as possible.
Excellent, thank you for that. Councillor Benton, please.
Thank you, Chair. I just wanted to ask section D, where it says continue to transform community and urgent and emergency care to prevent inappropriate attendance of emergency departments. Obviously, during the pandemic, a lot more people were attending because they couldn't get into the GPs. What exactly does that mean? You're going to continue to transform community and emergency care to prevent people attending when they don't need to? What are Calderdale going to do to prevent people attending when they don't need to?
Neil, do you want to start off on that?
Yeah, so when we've looked at the data, a lot of the not seeing a GP and turning up to A&D is anecdotal, but we do take it seriously and work on it. And we have been working across health and social care, and Sean and Ian have been involved in the urgent care response contract, which is a national pilot, which is coming out, which requires interventions to people in the community within so many hours, I think it's 2 hours, to try and avoid hospital admissions. So these are potentially people who are frail, elderly, at risk, where we have that multidisciplinary approach to be able to visit them and assess them within a certain period of time to avoid them going to A&E. So that is a priority area of us. We've received national funding this year, and I think we awarded the contract at Christmas, and are in the recruitment process now to sort of mobilise an action here. So it builds on that and brings in some tougher targets for us to be able to respond quicker. The key, a bit like the elective with all of this, is workforce constraints, because the same types of people that you need are the same types of people that are stretched in health and social care now. But that is something our community partnership board has been working on for some time across health, social care, mental health, community and general practice organisations.
Thank you, Neil. Councillor Benton, so did you want to come back?
No, that's fine.
Excellent. Councillor Barnes then, please.
It wasn't my point, but I'm going to follow on to what Councillor Benton raised, which is a very important point. But I think the issue there is behavioural pattern of residents or of patients. You can put as many processes and procedures in place. If person X wants to go to A&E, person X will go to A&E. And unless you change that behavioural culture, it will never change. It will never change. I think where I would like to point out, and this is in no way, shape or form any criticism of any of the people involved here, this committee or individuals on this committee have expressed concerns and nervousness about the change in April. And Councillor Swift quite rightly says, how will this improve the residents of Calderdale? It's a question she asks regularly, and it's actually an extremely important question. And I still think we are now a number of months out. And once again, this is not a criticism of anybody here, because you're working with your hands very much tied behind your back. We do appreciate that. But still that nervousness persists. And I'm getting extremely, I think that nervousness is starting to increase as the period shortens. And I think it is important that we keep a very tight eye on this. Thank you, Chair.
Thank you, Councillor Barnes. An important point there. Neil, do you want to add anything to that at the moment? I'm sure you equally have sleepless nights about the various changes.
So there are a number of changes. I think there has been a letter, I'm not sure how widely it's been shared within the council, that confirmed some of the place-based leadership arrangements. So within Calderdale, Robin has been confirmed as the place-based lead, and I've been confirmed as the Chief Operating Officer, which gives us some certainty around sort of responsibilities. And the committee that Ian and Debs are heavily involved in setting up is in its final throes of confirming its membership and moving into an operational and shadow arrangement ready for when the reins are handed down into July. So it is nervous, but I am confident that everything that we're doing builds on the Calderdale Care principles and does respond to the needs of patients in Calderdale. And I think one of the key points in the planning guidance, which is sort of hidden, a lot of people don't go on it, is about using that data. And we are very much wedded in Calderdale of using that data to argue our cases for various things, to address our health inequalities. and two, do things for the benefit of our residents.
Thank you, Neil. I think one element that concerns me relates to effective communication, because actually, whilst we are in the know, and we're not really, we're finding these things out. I think it's really important to ensure that our residents are brought along the journey rather than suddenly, oh, actually things have changed. What's been done to address that communication to ensure that people are aware what's going to happen step by step, really.
So I know within West Yorkshire there is a central communication function which is looking to work with places and build on the networked relationships that we've got to ensure that the communication goes to partners. I think probably communicating with Scrutiny is probably one of those things that we probably need to work on. I think a significant amount probably comes in at leadership level, and it's how we work to ensure that it's disseminated out and everyone gets sight of and is aware of what's going on. But there is a huge amount of communication, I think sometimes too much, but then clearly we're not hitting it in the right park all the time. So I can take that back.
Yeah, thank you for that. Councillor Megan Swift.
Thank you. A couple of quickies really, and one of them's timetables. I was told that children's timetable of waiting for child speech therapy was a high number of hundreds of hours, which gave me a bit of an issue. And I can't get anybody who will tell me what the adult number of waiting list for adults. So I'm obviously not going to the wrong place, or unlike everything else, it hasn't got a waiting list. So we should be pleased about that. But please, anybody who can do anything to help on that one, it would be appreciated. But things like the speech therapy, what's it? Councillor Barton's, I've got him. Yeah, did talk about, some of the other things. He came up on oral health, but, we're not knowing what had happened. I didn't know that we'd gone to a private company for some of the mental health stuff. And I don't know, nobody else is going to know either. Right, let you go.
Thanks. Neil, do you want to come back on that?
So I'll take that question away. Unfortunately, I don't have the information to hand about adult speech therapy, but I can have conversations to understand whether there is a waiting list there. I think just on your last point, we utilise a number of private providers for a number of things and have done for years. And I think we're very clear when we do use it. And I think committee probably needs to be aware that part of the elective recovery will be utilising the private sector. And we are looking at, particularly across West Yorkshire and being led by NHS England, what is the opportunities out there with private companies to help improve where possible, any recovery. And we've had success with Calderdale and Huddersfield using some private companies, particularly around ophthalmology, and reducing the backlog there during the last few months. So I know politicians will have their views on private companies, but within the NHS, they do have a benefit for patient outcomes.
Thank you for that. Councillor Hutchinson.
Thank you, Chair. I mean, regarding that, obviously, private companies or the so-called independent sector doesn't train doctors. They don't employ doctors. So the doctors that are being used there are trained at the public expense and are usually working in private hospitals in their spare time. There are also differences in the level of supervision of patients overnight in private hospitals compared to NHS hospitals. So what are they called? The resident medical officers don't have access to the intermediate tier of support from more experienced colleagues if problems are occurring. It's all dependent on whether they can find the consultant who that patient is under the care of, to see if they can give some support. And the safety guidance or the safety strategy framework that private hospitals work under is different from NHS hospitals. So, you know, I would certainly like to see, if they are going to be receiving their treatment in private hospitals, that they have currently within NHS hospitals, and that there should be the same level of transparency if more use is going to be made of them.
Thank you, Councillor Hutchinson. Looking towards possibly Anna on that one.
I think you know, the comments that Councillor Hutchinson said there around the differences between the service models across providers is you know, an insight into that. I think there is a definitely a very important contribution that working with the whole raft of providers and independent sector providers to help us deliver NHS services and address our backlogs, I think is really important.
Yeah, no, thank you for that. As you're aware, Anna and Neil, we want to work with you. We want to go along the journey with you. We are your critical friends, as you always know. So we don't want you to go away upset and hurt. But we do want to be updated on the good and the not so good, more negative aspects of what was, you know, what we're going to be facing on a day-to-day level. So very much appreciate the report. Nobody else has indicated to speak. So I'm going to take the recommendations as suggested from Councillor Barnes. So you will provide us with some that information at some stage in our work programme. So thank you for attending. We are your critical friend once again. And we'll move on to item number 5 now, which is the burnt bridges. So we welcome the independent chair of the safeguarding board. I'm just looking around, everyone's changed. Everyone's changed direction. Marianne, welcome, Marianne. You know, you have brought the burnt bridges report to us. We don't really want to go over old grounds, but we want to focus on moving forward, in my view. So, Marianne, do you want to add anything to the report that's already here? We welcome Rona as well, and we'll welcome Julia somewhere. I've lost her. But yeah, hi there. You're right in front of her. So yeah, welcome. So Marianne, after you.
Yeah, just briefly, I won't repeat it, but as you know, Burnt Bridges was a thematic review of the tragic lives of 5 men who died within a short period of time, who lived street-based lives. It's had a really significant impact on the way that we think about homeless people in Calderdale, but significantly has made a real difference to how agencies are working together to support those people with multiple and complex needs who need our care and support. So today really is a short PowerPoint presentation with updates from Julia, Sean, Rona, to explain really where we are now. So it's a bit of an update. Sadly, Neve can't be with us, but Rona will address those areas in the presentation. So I think it's just to hand over to Julia with the presentation, and then we can answer any questions once we've finished that.
Yeah, thank you very much for that.
Councillor Blackburn, are you okay with me sharing the screen?
Yeah, please do, yeah.
Fingers crossed.
It started, there we go.
Thanks. I've lost you, so you'll need to speak if instead of making face or pointing if you need to. You've all had the presentation, and we just wanted to give you a bit of an update since last time we spoke to you and saw you and gave you an update. Our desire for this was to get updates from those who are directly involved, so either leaders, managers or frontline practitioners who are actively involved in this piece of work. And Councillor Fenton Glynn attended a Burnt Bridges Progress event where each of those sectors presented where they were up to with regards to successes and achievements, also any barriers and anything that they wanted to kind of raise and escalate to the Safeguarding Adult Board. The other work, and I won't go through line for line, is trying to get messages out there to the widest possible workforce. So that has included briefings, we call them 7-minute briefings, videos. We've had a very, very powerful video of people in recovery and friends of the men who died who have read out the lives of those gentlemen who died, which is probably the most impactful piece of work that's been produced. We held a learning event, or called it a launch event as well. Again, looking at that wider workforce. Dr. Warren Larkin, who is a professor and researcher and leader in the field of trauma and adversity, did that with us, with Neve, and with that, showing that video of the men. And we've presented progress in various different forums and asked for their contributions. And I'll come back to exactly kind of what we're asking people, where we're up to now and what the next steps are. Just hand over to Sean.
Thank you. Sorry about that. I was just trying to find my, I'm so used to using Teams. I couldn't find my Zoom mute. So this slide and the next slide is really about the progress that we've made and this is the really important thing really, as a group of operational services right across the board within the council in terms of public health, adult social care, neighbourhoods directorate, housing, homelessness, and also our external partners, strategic partners. And in terms of the kind of realization of that, or how it's become more tangible, there is a specific focus, particularly with this population. It's a small population of people. It's about 150 in total, where they have the core kind of core complex needs of street-based lives with many kind of complications around that. But where we've made the progress is in terms of, and this is a lot of work that Neve and public health colleagues have been doing with ourselves too, around making sure that there is outreach, regular outreach and recovery workers and experts by experience. And those are people that have previously used services. And I've been down to certain places in Halifax with Councillor Fenton Glenn as well, where we've seen that in action. There's assertive re-engagement, and that might sound a little bit heavy, but essentially that is about making sure that there's more flexibility, particularly around substance and alcohol misuse support with people who are deeply entrenched with their addiction and their lifestyles. We've got much more closer working relationship now with the policing team, much more so recently. And that's mainly been because there's more consistency and focus from the police and their understanding about how to work with this group and the willingness of working with other agencies to support us with that. So that's really kind of come on and been a very kind of positive development in the last couple of months. And particularly as well, which is crucial, working with landlords, one landlord in particular, again, near to the centre of Halifax, where with the police and with community safety, us and a number of other agencies, there's been some really proactive support with this group of people. And again, within some tenancies within this project near to the centre of Halifax, there will be 2 tenancy sustainment workers to actually work with the landlord and the tenants to see how they can start to improve the environments that they're working in. Plus, there are other ideas around bids to look at around the improvement and the hard targeting of kind of security, where this group is quite vulnerable and they are kind of targeted by a number of kind of outside groups. So there's a whole lot of work going on there in terms of making the place safer and the quality of life better. And that's going to be part of the Tenants Association. The next slide, just very briefly, is an example really of where we were, I wouldn't say we were going wrong, but where there were silos. And this was kind of during the period of how we were looking at the recommendations of Burnt Lives, and actually having some really truthful and open conversations, challenging conversations across all of the agencies about how we really need to kind of break down our preciousness as agencies, really, about our areas of work. So, for instance, instead of saying that people needed social care act assessments necessarily, that wasn't really the point. We were missing the point. It was more about what was needed for that person immediately, and flexing services around them. And this slide is just one example of the growing number of people that we're now positively working with, where services are less precious across mental health, housing, adult social care, and understanding the person. And that's particularly the case through the new and evolving multidisciplinary team approach that we've developed. We've still got a way to go with that, and it meets on a weekly basis, but it's putting the resources in to make that happen. So that's certainly been progress over the last 6 months in terms of a positive impact on people's lives.
Thanks, Sean. I'll bring Rona in now if I can.
Okay, thank you. I'm going to just feedback on the work that's been undertaken by in the NHS, and I lead on the work, the recommendations from Burnt Bridges review around health actions. And I've been to Scrutiny before and talked about these, but there's a lot of work that's going on that sits across this work. As Sean said, it's about joint working. So although this says NHS, this is about a lot of people working together and being really passionate to move this forward. So this report, this first slide shows you some of the service developments and some of the training that have happened. We've made significant progress since we were last here, especially around the training within general practice and across the board of areas around trauma-informed training and safeguarding training to bring people up to speed with this area. And that was one of the key things that we said we needed to do as a start of the 10, really. There's lots of work that's happened in the service development where people who are, as I say, are really passionate about this have actually just started some pieces of work and got involved and said, we're going to make some changes, and they're really positive changes. And some of that is around the wound care clinic and the sexual health clinic at the Gathering Place, and the trauma inquiry pilots in GP practices that are being planned going forward. So there's as I say, there's lots of passion and interest there that's helping us to move this forward. A couple of key things that we were asked to do was to review pathways from the action plan in the CCG, and it was across dual diagnosis. And if you remember, we had that conversation about have we got the buy-in from our partners to do that, and we certainly have, and that's moving forward now. COVID and the Omicron did slow that down and pause that again, but actually it's moving forward at pace. People are really engaged with it. And we started to do some work around the ask was around learning from the risks and the gaps around the pathways, and we've been starting to look at those both for adults and for children and young people and mothers as well, as was the request. And we did a piece of work yesterday with the Children Young People Open Minds group, and it's a partnership group, so it's got a wide range of partners there from across Calderdale, and we focused on the complex needs of children, young people. And it was a really good piece of work that people are so passionate and so want to get involved in around identifying where we've got gaps and what we need to do, and learning from that whole element of the young person's experience. Because these five men, a lot of the information that was gathered, you could take some of that back into the childhood experiences, And we need to learn from that, and we need to address that. And we've done some really good work starting with that. And what's made me realise there's lots of other pieces of work that we need to connect together to bring this together, to join it up. But I wanted to just give you an example of that from yesterday, because we saw a lot of people coming together that are really, really passionate about this. If we go to the next slide talks about the strategic leadership and the commissioning. So I've kind of pulled out some key areas from that. The dual diagnosis subgroup is set up. We've got all the partners around the table, and we're walking through the pathway and identifying where the risks are, and identifying where the gaps are and what we need to do differently. So again, it's a piece of work that's we've got partnership involvement. There's engagement in the means strategic group, which is making every action matter. And there's a big piece of work around West Yorkshire around trauma-informed system, and with a plan to have the trauma-informed system in place by 2030. And we are heavily involved in that from Calderdale at a place base. So we are leading and working and linked into that piece of work, which is really, really positive. I'll stop there and allow next slide and let people.
Thanks, Rona. If we move back to Sean, thanks.
Yeah, so this is in the absence of Heidi and Nicola, who weren't able to make it today from housing and homelessness. But essentially, this is just an update, and it was stated at the previous scrutiny update on the development of initiatives for people who are rough sleeping, particularly the pathway. So as you can see on the slide, there continues to be a flexible approach to how people are being supported, and that again exemplifies what I was just saying earlier on in terms of this multidisciplinary but not precious approach to how we really need to support the engagement with this group. There are new homes coming online or have come online, new steps or next steps home, I should say, for people to access independent housing and support. The winter shelter that has been around this year, that was upgraded as well to accommodate people over the winter period, which is still open. Ryburn House and crash pads as well. And then getting back to what Rona was talking about, what we need to remind ourselves constantly is that we are working with young people who will be adults who are living with trauma. And it's knowing how we can have the sets of skills really to work with these people who have some of the most kind of complex, difficult lives. Who find it very difficult to express or communicate what they're feeling. They usually do that through self-harm. So the emphasis, and it's been kind of re-emphasised through the Safeguarding Board and other strategic groups, is to have a workforce that really understands and is trained around trauma and understanding how to work with that group. So the second part of this slide is very much about that, really, and making sure that we are putting resources into that from a housing perspective, but also all the other support agencies. Can you put the next slide up, please? And then this is just a graph that's outlining the access that people had, particularly obviously during the pandemic through 2020. 21 and where they accessed accommodation. And as you can see, just over two thirds of people, again, who were kind of either living street-based lives or were sofa surfing, who didn't have kind of sustainable housing or consistent housing or accommodation, have continued to access and remain in secure accommodation. Yeah, that's it. To the next slide, please.
Lovely, thank you. And over to Debs now, please, Debs.
Brilliant, thank you. Yeah, so I'm just going to give you a little bit of an update of the work that we've been doing through our substance misuse services. So, I mean, the key approach that's really been taken has been about joining up the support that we give to people that misuse substances in Calderdale, and actually taking the services, all the support to where people are, to the basement project, to the gathering place, and actually engaging with those service users, hearing what matters to them, what their issues are, where they want to be, and then taking, rather than expecting them to go to different services, actually taking a wide range of support to the basement project, the gathering place, etc. And I think that's really been successful. So you can see, I won't go through all of this slide, but you can see that we've really tried to improve and increase the capacity for substance misuse, for recovery, and also for harm reduction, so that people that are using substances are supported to have access to treatment that will stop them, reduce the likelihood of them overdosing, and also us making sure that we're meeting the needs of people with really complex needs in our substance misuse services, for example, through our detoxification services, and then as Rona's already mentioned, the work that we're doing around your diagnosis, and we're really taking that multidisciplinary team approach. We've got a health and wellbeing nurse who's actually talking to people, identifying what they need to do, and then either supporting them themselves or drawing in other services like wound care and therapeutic services that they need, and I think what's really important actually is to share the next slide, which is just some of the stories, some of the comments that we've had from the substance misuse service users since the burnt bridges, since we put in place this new way of working. So you can see there, thank you for everything you've done for me and many others. You're a lifesaver without doubt, and you should be proud of yourself and the work you're the best key worker I've ever had, etc., etc. And you can see a parent said, following the death of my son, I would like to donate £100 to support your clients and say thank you to the staff for the hard work and support. And then another example there of a service user who attended a restart appointment and wanted to thank the staff member for the persistent in contacting, not giving up on people, trying and keeping people engaged, and thanking the workers, you can see there, for not giving up on me. And just really recently, just last week, we took the COVID vaccination clinic to one of the areas where people that are currently using substances in Calderdale are, and vaccinated 18 of the people there with the most complex needs, to support them from COVID. So really that's the key approach that we've taken the services to where people are, to trusted locations, trusted venues. And I'll hand back over. I don't know if it's you, Julia, now.
Yeah, thanks, Deb. So just to clarify, what we're working on now is what the actual procedures are, exactly terms of reference for all of those things that you've just heard about. How they will be supported through management, business support, facilitation. At the moment, there's a lot of goodwill of people like flexing and doing on top of their own roles, and that just needs clarifying. We're looking at making it easy for ourselves to share that information following GDPR, but looking at what other places are using and how they're being successful in making it simpler for people to do that. And also looking at actually the governance and accountability of this. And as you've just heard, how it also fits with adverse childhood experiences, antisocial behaviour, suicide prevention, and a lot of other agendas. What we're expecting from Calderdale organisations, therefore, are these four major things. So aside from the individual and the multi-agency work that's just been, a little bit has just been described to you, there's lots more going on. These are the kind of overarching asks for organisations, statutory, voluntary and community, is looking at making sure your staff are awareness raising and trained and working in a trauma-informed way. I think if we get anything out of this review, it's a legacy of that trauma-informed way of working. Supervision then to really reflect on whether the practice is like that, and looking at effective safeguarding supervision for frontline practitioners. Never giving up, as we've just heard from a service user there, about how important the culture of never giving up is. Breaking down barriers to engagement and support, and then looking at discharging and disengagement procedures, and looking to see are they fit for purpose, in light of the learning from the Burnt Bridges review. I'll fly through these because you've heard already about the progressing dual diagnosis, the formalisation of the multidisciplinary plenary team process. There needs to be a strategy and action plan behind all of this. Quite importantly, the next two is the challenge events that will follow. So actually, what difference has this made to the lives of the people who live in the community, to frontline practitioners who are actually working with these procedures? So we're going to really test out actually what impact this has had. We do this for every review that we do, and we usually generate more learning actually. But that's probably one of the most important elements that is one of our next stages for this. We'll be gathering evidence of the impact and outcomes in other ways too, data audit, case studies, lots of other ways. We're looking at sourcing further trauma awareness training. All the training that we've offered so far has been fully booked, oversubscribed, and so it's more. We're producing a trauma briefing. So we've already done briefings on the actual report, the learning from Burnt Bridges. We're specifically looking at trauma now, what that means, what is it, people still get asked, what can I do? And looking at the differentiation of trauma briefings for different age groups. So what's trauma for parents, for babies, through childhood. It means different things to different age groups and different situations, and launching a fatality review process. So we won't be undertaking a huge review like this unless we know that it meets the criteria for a safeguarding adult review. What we will be doing is looking at what Calderdale looks like in terms of our fatalities, and see what further learning there is through that process. Which brings me to the end, and so I'll stop sharing and hopefully I can see you all again and open up for questions.
Thank you, Julia. It sounds like you've come an awful long way, an awful lot has been learned. I've got 4 people indicating to speak now, so we'll start with Councillor Kingston, please.
Thank you, Chair. I've actually got a few questions and comments. I hope it's all right for me to pose them all. I'll do them in one at a time, shall I?
Yes, yeah, no, that's probably the best way. Otherwise you don't quite get
so we don't get too confused.
Yeah, absolutely.
Okay. I did again struggle with some of the terminology in the presentation that we've just been given. So I just wanted enlightening as to what some of these things mean. For example, I don't know I think I've worked through most of the acronyms, but not all of them. I don't know what is meant by a trauma inquiry pilot. What's a trauma inquiry?
Julie, do you want to answer that one?
You might need to enlighten me about where that is. Whose slide was that on?
It was on the NHS response to Burnt Bridges.
Might be Rona that needs to come back on that.
That's testing me. I don't know exactly what's involved in that, because it's done in the NHS. As I say, it's not all by me. So there's different elements of being involved in people being involved in that. But I would imagine that somebody's doing some sort of inquiry into primary care and the input into trauma. But I will come back and give you a full response tomorrow. I'll find out.
Thank you. I just wondered, is it something along the lines of that GPs given guidance on how to check with their patients to see whether there's some trauma underlying things? I thought, is that what it is? But I didn't know, so I didn't want to assume that I'm correct in my guess.
It is, and I'm sure Rona will feedback, but yeah, it is essentially that the GP is asking more questions rather than just treating symptoms.
Right, thank you very much. Okay, that's number one. And then dual diagnosis. What is dual diagnosis?
Debs or Rona, do you want to come in on this?
Yeah, I can explain that. So dual diagnosis is people that have both a substance misuse challenge and a mental health challenge, and it can be quite difficult because historically it can be quite a challenge for services to treat just one of those two things rather than work on the mental health problem and the substance misuse problem at the same time. So we call that dual diagnosis. And people that have both of those challenges can find it more difficult to get effective treatment unless we work differently and work much more in a much more personalised way with the service user.
Excellent. Thank you very much. Right, a few comments. Firstly, just while you were doing the presentation, I thought, you prepared really well for this. I was impressed by the preparation and group preparation, how you've worked together to prepare for tonight's meeting, which I think reflects the amount of work that you've put into this whole area, full stop. So just to acknowledge that. Then again, and I've commented previously, I was pleased to see how much actual practical stuff has been done to reduce rough sleeping, the amount of investment that there's been in place of beds and places for people to stay. Very impressed by that. Just one comment on the housing response page, the support around effective behaviour management and support those with complex behavioural needs. For example, clients who have specific disorders with attention-seeking behaviours and thrive from coming into contact with emergency services. And it just struck me while I was reading that it would be easy to read that as a criticism of those people. And I just wanted to stress that those are symptoms, that having attention-seeking behaviour and thriving on contact with emergency services is a trauma symptom in and of itself, and that we need to be careful that we're not passing judgment about people in terms of the way that they're presenting to us. And just as another thing was, if they're thriving from coming into contact with emergency services, well, that's a good thing. They're thriving. Thriving is a good word. If it's inappropriate that they're contacting emergency services instead of other services, then we need to look at why are they contacting emergency services instead of more appropriate services for their needs. So that was it. Thank you very much.
Thank you, Councillor Kingston. Does anyone want to respond to the last point? Use it more generalised, Julia.
I think Sean might have said he had his hand up at that point, but actually that was the point that they wanted to get across from the service, was actually now that is exactly what is being seen, and therefore support for those people, support for that, for those, as you say, presenting symptoms. That's all they are. It's actually finding out a lot more. So yeah, that was exactly the point of the example, Councillor Kingston. Yeah.
Sean, do you want to come back in on that as well?
Yes, thank you, Chair. Just to add to that, really, I think actually it could have been worded better, really, because it comes over as subjective, and it wasn't meant as that, I think. So, I mean, you're absolutely right. It is about people who are engaging with, and sometimes over-engaging with, certain services because they need to. There's a reason for doing that. And I think using the word thriving from that probably isn't the best use of that language, really, but there is a reason for them to do that. So I think we needed to probably carefully rephrase that, because it is quite subjective. That was the intention.
So thank you, Sean, for that. Councillor Megan Swift. You're just on silent at the moment, Councillor.
Oh, it's gone now. It was
There we go. We've got you. We've got you.
Thank you very much. a couple of things again. I mean, I had the same problem with Anne Kingston about the number of initials that are scattered in the report. I mean, I did say to somebody, when I first came on children's services, going back to when I first came on the thing, I used to take hours and hours going through reports and going back as a post to try and find the initials. I haven't had to do it for a long time, but this one was one I had to. So, I mean, I don't particularly like all the initials put together, but it's better than not being there at all. And one of them that Councillor Kingston knew off the top of her head, I haven't picked it up as that. So if we're going to get the story right, we need to know what those are. We talk, and I don't know whether it's in this one or one of the others, about every man matters, every adult matters. Yeah, sorry. We seem to have a collection of every child matters, every age-friendly person matters, adults matter. You know, and we're going to start saying everyone under 2 matters, or everyone over 50 matters. It doesn't seem as though there's any importance put to it, because we're doing so much of it. And I don't think there's anything else. One of the things that I thought was really good was the training, and the fact that a number of training was being given all to anybody who would come through them. I assume the voluntary sector, as well as places like the doctors. And yeah, thank you very much.
No, thank you, Councillor Swift. I think it's a really relevant point in relation to acronyms, making sure that we just fully understand so we don't get confused.
That'd be my fault, Councillor Bagran. I apologise to Scrutiny there. And just with making every adult matter. And yes, we're looking at what we're going to call it, but actually is a nationally recognised term that we've kind of used. But yeah, I take your point.
No worries. Councillor Hutchinson, please.
Thank you, Chair. I mean, there's obviously been a lot of imaginative and collaborative work been going on over the last, well, we scrutinised the burnt bridges report in July last year, and particularly around housing and the work that's being done centred on the basement project, and you know, it's very impressive. But there are several areas that we picked up on at the last, that are in the minutes of the last scrutiny meeting, elements that were missing from the action plan. One was the dual diagnosis service, where there were no timescales and nobody had accepted responsibility for. Another was service for people with intellectual disability. Now, it sounds as if you are at least having discussions about a dual diagnosis service, but it sounds as if there is no dual diagnosis service yet. What are the barriers to actually establishing that? And when might we actually expect to see a dual diagnosis service available in Calderdale?
Ronald, you look like you're ready and raring to answer that one.
So, yeah, sorry if we led you down the route line that there wasn't a dual diagnosis service. There is a dual diagnosis service in place. What we're looking at is whether that is the service that we want to continue to commission, or whether we want to increase that service and understand where the gaps are. So we have the partners involved, and I think last time you asked if the Mental Health Trust were round the table, and we were saying we were in conversations with them to get them in discussions, and they are definitely around the table. They've put additional resources in to support at this point while we're working through some of the gaps. So they are definitely involved. There is a service in place. What we want to do is what we were asked to do was to review the pathway, to look at where there are risks and to look at where there are gaps, and then to produce a pathway that would be you know, that would be complete pathway for the meets the needs of that population, of that cohort. That's what we're in the process of doing. So we're working with partners to work through that pathway and identify those gaps. It's a complex pathway. It's not an easy pathway, but that doesn't stop us doing it, but it's a complex pathway.
I mean, with all these, with this particular group of individuals, everything, flexibility is the key. And trying to constrain things into rigid pathways doesn't work. That's one of the main contributors to how these guys ended up in the position that they did. So
and we've been talking about that and about the no wrong door approach, and that people have to be flexible and agile in the way that they accept people, and how do we do that in order to make it work for both services, but more so for the people. And that's the bit that is the bit that we have to unpick and takes a bit of time, but everybody is on board of that with that, and we've said it's everybody's business. So we have to do it together, and that's where we're working from. So totally agree with that, Councillor Hutchinson.
Oh, that sounds absolutely the right way to go about approaching this, and good luck to you. So is that what it means by the statement, standard statements in contracts / service specifications, so that services aren't just working within rigid contractual boundaries, rigid criteria for taking patient, accepting the care of individuals?
It is, and we've done, I mean, some things are quite small that we've achieved, and you could say this is small, but it's big in the state of the change in a contract in the NHS. We've now included wording so that it's more flexible about who people accept. We used to put things in such as it's only accessible for people who are registered with a GP in Calderdale. That wording has been removed. And we've put some standard wording in around this cohort, so that goes into every contract and every procurement that we undertake now within the NHS or the CCG. So that's what that refers to, is that our contracts weren't really flexible. And we've now addressed that, and that's gone through our governance process and has been approved, and it's now in everything that we do.
And I would hope that attitude sort of pervades the other areas of contracting for the maybe not quite so complex patients too. Can I just ask
across the board, Councillor Hutchinson?
Yeah. Can I just ask one more question? It's about, you told us back in July that the system is looking to introduce a multidisciplinary recording system that has interoperability with adult social care and the mental health recording system. Have we got that interoperability and integration of the recording systems yet? And if not, what are the problems that are standing in the way of that?
I can answer that, Chair.
Yes, of course. Yeah, please do. Yes,
Yeah, sure. So what we're looking at, we're working on identifying resources and looking at bids to develop this model, so that there is a set of resources and personnel as well as infrastructure around this. And we've been looking at, well, specifically working with one area that has a standalone electronic recording system that works very well for this group, which we think potentially we could use in Calderdale, but we're still looking at the feasibility of that. Going forward, though, it is going to be a bigger challenge, because we have this challenge within our own bigger system within adult social care and within the health system as well, about how a system like that can be interoperable with the bigger statutory systems. So that is going to be a piece of work that will take a good while, really, the next few years, really, to see how it can work, how feasible it is in truth. But as far as a standalone system that disciplines can work with, We think that it's likely not to be too expensive and something that can fit to Calderdale's needs, really, the purposes that we would use it for.
Okay, thanks for clarifying.
Yeah, I'm going to bring Debs in at this stage. I think she would like to comment on something.
Oh yeah, thanks, Chair. Yeah, it was just going back to the dual diagnosis question that Councillor Hutchinson asked, and just to say that I think we've got the building blocks with the multidisciplinary team approach, with the work that Ron has described. But just to remind you that the big drug service, substance misuse service review that Dame Carol Black undertook, that's informed the new national drug strategy. Really puts all of this on a much stronger footing moving forward. So additional resources come into each local authority area, and really starting to think much more about substance misuse as a health issue rather than a criminal criminal justice issue. I think will really help us better meet the needs of this particular community, this group of people. So while we're not there yet, I think dual diagnosis is a good example about whereby really strengthening our partnerships, strengthening the local provision with some additional resources. We've got the opportunity to really move forward.
Excellent, thanks for that, Debs, and the clarification is really helpful. Councillor Parsons-Hulse.
Thank you, Chair. Oh, I'm so excited. I'm really pleased to see this piece of work. It's great to see that you're doing so much around person-centred care. I think it was like 4 years ago, I think, that I mentioned the word trauma-informed approach, and it I remember it just seemed to send everyone into spin. And I'm really excited that you're training people, and it's fantastic to see. Can I just ask a few questions? One of them is, can you tell me what psychological theory is underpinning your training? So are you using polyvagal theory? Is it attachment theory? What theory is underpinning that? And so you're also looking at who is delivering the trauma-informed system training? Are we doing that in-house, or is that something that we're got a private sector person to deliver? Is the second question. And then something around the non-verbal. So the way that trauma is stored is in the amygdala, is in the non-verbal part of the brain, as you probably know. So one question is so if we use verbal therapeutic intervention, obviously we only get to a certain place with that. So what non-verbal therapeutic intervention are we using to deal with trauma? Thank you, Chair.
Oh, thank you, Councillor Parsons-Hulse. Right, it's above my pay grade. So
sorry, I work in the profession, and I feel as if I don't say anything here, then
I thought I'd walked into a foreign language course for viewers. Julie, would you want to elaborate, please?
Yeah, on some, yeah. So far we've used professionals from SWIFT. So South West Yorkshire Partnership Foundation Trust have delivered our training for us so far. We've obviously added the intervention, as I've described, from Dr. Warren Larkin. I would have to find out for you what theories are underpinning and the non-verbal therapeutic interventions. So I can feed that, but I can get back to you on that. We are, as somebody mentioned earlier, working with the West Yorkshire Integrated Care System, where their focus is on adversity, trauma and resilience. And they're actually developing training, raising awareness for West Yorkshire. We felt like we had to get on with it straight away, so we actually didn't wait for them to develop this. So we are hoping that it won't be too long until there is a West Yorkshire approach that we all buy into. But so far, as I say, we brought in local professionals from SWIFT, and we're looking at sourcing further right now.
Right, that's great, thank you. Yeah, it's really, there's something there, isn't there, about using the polyvagal theory, because it means that so that for members who don't know what it is, it's fight, flight, freeze and fawning. So there's those 4 things, and basically when we look at those, it creates safety. We repattern it. And what you were saying before about the substance misuse, Deb, I'm really excited to see that we're looking at other ways so that it's not seen as criminal, because I think many of us here know it's more connected to numbing those difficult traumatic feeling, you know, the traumatic response in the brain. So yeah, thank you for the great work you're doing. I'm really excited to see how it's going to unfold. Thank you.
And thank you for raising the more technical issues. we do appreciate that. Councillor Durans, please.
Thank you, Chair. I'll just go back onto my notes. Again, in regards to some of the references around the behaviours or the symptoms that may be presented, I just wondered, when you've got people that are living within these situations, the services, I guess, that they're engaging with, what their understanding and knowledge is, as in signposting, directing, because again, I'll reference what a couple of the other councillors have said, but we know that there are well-known information around self-medicating, not necessarily to just deal with trauma, but if you are neurodiverse, you may self-medicate because of some of the symptoms, which then can create dependency on drugs. And without that first kind of understanding and engagement, we're going to end up attempting to rehabilitate people that will naturally fall back into that system, I expect. And then I've got another question, if that's okay. We've got 68% who have secured accommodation, and then 32% who haven't because they've left before we could work with them. They've returned to custody, they are in hospital or are still working with us. I'm not quite sure what that means, and I wonder if we have a more specific percentage in that area, and whether we've been able to re-engage with some of them and attempt to get them back into, you know, off the streets. And there was another question, but I've lost my trail of thought, so I'm sorry, Chair.
No,
but yeah,
no worries at all. If you want to come back on that one, that's fine.
Thank you.
I'm looking nobody's nodding. They're not blinking. Julie, do you want to?
Yeah, I wondered if Debs, did you want to come back in on the first question? But certainly there's a risk mitigation approach. It's not always abstinence, or, you know, the end goal is not always to come off drugs. You know, there are lots and lots of individualized, flexible approaches to how services now are working with people. Debs, I don't know whether you want to probably.
Yeah, no, thanks, Councillor, for that question. I think there's a few things really that as I was listening to you that were popping into my head. I think the first one is Julie is absolutely right. The personalised outcomes for people in terms of the support that we give them if they are, you know, misusing substances. So it's what their goal is, what do they want to achieve? And obviously for many, they want to recover, they want to become abstinent, but others, what our job is around harm reduction. It's around, you know, preventing serious illness or death for those that are using substances. And I guess the other bit of your question made me think about the early intervention work, and actually the work that we're doing through our refreshed wellbeing strategy, actually, so that every child gets the best start in life, and that 15-year-olds in Calderdale have got hope and aspiration for the future. And both of those, that sort of really using those universal services that we have in very early childhood, actually, 2.5 year checks, really using what we learn from those to identify people that are greater risk of not being ready for school, not having good outcomes later in life, and actually making sure that we use that information and then deploy it to reduce that risk moving forward. And equally in the adolescence, and we know that it's those transitions, isn't it? It's when it's new families, it's the transition to school, and then it's the transition out of school into the big wide world, isn't it? And at those points, us making sure that we're really looking and identifying risk as early as possible, so that we can put things in place for those at a greater risk of having poor outcomes in their life more generally.
Thank you. Sean, do you want to come back in as well? I think you were.
Yeah, it was just to answer Councillor Duran's second point. The percentage in terms of those people, the 2% of people that have fallen into different parts of the system, probation, police, custody, the justice system in one way or the other, or just fallen away in terms of not engaging with any part of the system. In truth, to have such a high percentage of people in stable accommodation within this group is quite remarkable in itself compared to other places where I've worked. But that said, it's never good enough if it's not 100% in terms of people having shelter. And that is the real challenge of this work, whereby we need to close that percentage gap for people who are so disengaged. I meet with them fairly regularly, over the weekend when I pop into town, and when I'm in town, as we all do, and speak to them. I've got to know them personally, and well, not personally as such, but got to know their situation more, and to see how we can support. And their ability to try and engage and do the right thing is sometimes so limited when they want to, that they literally, because of the attractions of other people, substance misuse, whatever it can be, means that they fall away and come back again. And that is the real challenge for this piece of work, those people that are literally on the margins of what is, as said already, a very complex and traumatized group.
Thank you, Sean.
Sorry, could I just come back in there, Chair?
Of course you can.
Again, I'm just wondering if it's not necessarily that they won't engage. I'm wondering if it's they can't engage for whatever reason, because it's about that understanding of, we might not know why that is. They might not know why that is. If they're in crisis at that point, they are literally surviving. My third point was, Chair, and I don't know if this is a relevant question or not. The comments that we often share on these groups, we kind of take a snapshot of the positives. And I always wonder whether we collect some of the comments that when we haven't been able to meet needs, and then we can offer what we've done because of that. So, we all tend to want to focus on when it's gone right, but I wonder if we can ever share comments from service users when it hasn't gone right, and then what necessarily we could have put in place or we have put in place. But if we only ever reflect on what's gone right, we kind of can't see a journey, can we? I just wonder if that's ever considered.
Thank you. I'm going to bring Marianne in at this stage. She's indicated to speak. I think she might be able to help us.
Yeah, I mean, I think, first of all, your last sort of point was, this is where things did go wrong. The whole point of the Burnt Bridges review was when things have gone wrong. And as a Safeguarding Adults Board, sadly, is those cases that we tend to look at. That's not to say that when you review a case where there has been a poor outcome, there might be some positives in that. So this piece of work was around where things had gone wrong. So how can we make things better in the future? But I think the other point, just to reinforce really, is the report was called Burnt Bridges, and that came out of basically professionals saying, well, these people have burnt their bridges with us, they've not engaged, they've not attended appointments, they've withdrawn from services, they don't want our help. And what we've tried to do, and what we have done really, is to change that culture. So actually, you've heard about services now going to people. We're not signposting people, we're outreaching our services to those people, and we're not giving up. So I suppose that's the shift that we've made, we continue to make, is, away from people burning their bridges and services, not washing their hands, but stepping away, feeling that they don't want their needs met, to one where we're not going to give up, we're going to keep offering that support. And eventually, at some time in somebody's life, they might be prepared or might be able to receive that support, even if they're not when it's first offered. So I hope that provides some reassurance. But certainly as a Safeguarding Adults Board, our business largely with the reviews is to look at when things have gone wrong, to look at them, well, how can we put them right in the future?
Thank you. Julie, do you want to come back in on that as well?
Yeah, just Councillor Durrance, I think the next stage of this, which you just very briefly described, those challenge events or interviews, will tell us that, exactly that. we do challenge events after every review to see whether it's made any difference. As I say, you know, we may have services who are saying, yes, this is absolutely wonderful, fantastic. We can have case examples, we can have, you know, but where is the other stuff around apart from the positive? So we are interviewing experts by experience, people in the community, as I say, frontline practitioners, how it actually is it working? Are these new procedures working? Has it made any difference? What impacts it had on you positive? You know, we will do that piece of work. And as I say, usually every time we do that, we come up with more learning. Yes, this is great, this has changed, but actually we need to do more of this or whatever it is. Yeah,
So I was just looking, you've just put your hand down, Councillor Durans, and I was like, you're confusing me, trying to confuse me.
No, sorry, Chair. I was just going to say, I understood that obviously the burnt bridges was about learning on this whole. I think my comment was on the 3 comments that were shared from the basement project, specifically around a kind of array of comments of why people might not have felt the service at that time was free. I think Sean had referenced, you know, with the people that he's engaged with. But I guess it's just feeling that it's okay to share things that are not always glowing, you know, to give us a balanced review. That's just my opinion. But yeah, I did understand the whole scrutiny review at this point. So thank you, Chair.
Yeah, no problems at all. Councillor Barnes.
Thank you, Chair. I didn't think I had to duck very much when Councillor Parsons-Hull started mentioning the theories. And by the way, councillors, there is a test on it at the end of the session. I think Councillor Duran sums a point in the sense that, you know, that those 32%, and I think it was a concern that was raised when the Burnt Bridges report came to scrutiny. I think it was a concern about how do we manage, how do we look at those that drop out for whatever reason they drop out. And I think Councillor Duran summed it up when he said sometimes they themselves aren't aware of why they drop out. And I think that's where we need to still keep our activity high, that looking at them and ensuring that those people who do drop out, that there are other mechanisms in place and that we are continuing to look after those individuals. I think we have come a long way. I think we've come a significant way. I think there's some things probably on mental health that still probably need to be nailed down, tightened down and looked at. I think it's important that we as a scrutiny committee keep asking this to come back as a sanity check, maybe, just to make sure that things are progressing. It just takes it, you know, we don't want to be in a situation to do another one of these reviews. So regularly coming back and just having a separate pair of eyes looking at it, I think is a very important thing. So thank you, Chair, and thank you to everybody for their presentations and comments tonight.
Absolutely, I totally agree in terms of the presentation being excellent. It's a very extremely tragic circumstance, but a great deal has moved forward, you know, from this. As anybody, well, within this group knows that actually we equally have learned some lessons as well, actually, and that is communicate and have regular meetings with Marianne and Julia, which are extremely useful, and will continue to actually do so. Councillor Fenton-Glynn.
Yeah, I just wanted to kind of add a couple of reflections. Obviously, I came after the report had been released, but kind of at the start, well, I mean, we'd already started implementing some of the things before it had. But I just thought I'd kind of share a couple of reflections, just because I think it's worth underlining how much is being done and how well it's being done. It's one of the things when, you know, if someone says, you know, what are you proud about as lead member for adult services and wellbeing at Calderdale, then I would point to a lot of the work that we do and the fact that we've found the right partners. And actually, you know, the fact that a lot of it's run out of the Basement Project, which is a voluntary organisation which we're doing things the right way, and we built on that approach and that outreach work, rather than kind of coming in as a lot of kind of statutory organisations do and going, this is our model, and so wait, you know, if you can fit into this, then we'll commission you. But we've said, look, here's people who are doing things well, and now increasingly some of the other services are looking to kind of move into that, so it's more of a one-stop shop, if you will, and that's, you know, that's something that's really good to see. I hope it's something that we continue to learn on in other areas of our commissioning is finding the things that are working and working with people that are doing well and kind of engaged at the grassroots. And I think that's something that we can't underline enough. The point about people, getting them when they access the service is absolutely key. And just, there's been a few cases since I've been in this role where they have kind of got someone and they've been able to wrap the services around that person, and it's great to see them kind of looking out for that. But there is still work to do. And I mean, when I went around with the outreach workers, we came across someone who'd been turned away at A&E because they thought she was kind of not there for the right reasons, and she had quite she had a wound on her leg, and it was quite distressing to see. And I think you forget that this isn't something that we're going to blame people in A&E for, because it's a stretched system, it's an overworked system, and perhaps during the triage people don't have time to go through all of the causes that might get someone there. Luckily, because of the outreach work that was being done, there were people who were able to then pick up and make sure that she got the services that she needed. But there is still work to do there, and I think that's really important. And the final thing I'd say is I'd like to just pay tribute to some of the work that Sean's done, kind of constantly chasing up things that are happening to some of those groups. I'd like to pay tribute to Neve, who isn't here but is tenacious and occasionally terrifying when she doesn't think that we're doing it right. And that's exactly the kind of challenge that we really need, kind of from coming in from public health in this area of work. And it's been really, really useful to see. And also, it's not been discussed very much here, but the work at Craven Mount, actually getting people off the streets into an environment where they can be looked after, where we can look after the whole person, but also the really good work that's been done to keep the streets out of Craven Mount. When I was out with one of the outreach workers, I said to them, look, what's the one thing you're doing? They said, build 5 more Craven Mounts. Now, we don't immediately have the resources to do that, but it shows that where that service working, in fact, it is having a long-term impact. And, I'd just say, please, continue to support the work we're doing, but continue to ask us the difficult questions. So, yeah, thank you. And I'd like to pay tribute to everyone who's done their bit in making this really innovative work.
Thank you. Thank you, Councillor Fenton-Glynn. Just one final question for me to Julie. Is there anything you think the Cabinet or the council should be doing or commissioning additional to what we're already doing at the moment?
No, I think when I get the next training lot of dates, I'll send them over to you. And if you want to go on that training yourselves, that might be useful for us all. But no.
Yeah, be more than happy to. Thank you, Marianne. Thank you, Julia. Thank you, Rona. And thank you, Sean, for collating it's a really extremely useful presentation. And you're always welcome back here, as you know. So we go on to item number 6, which is safeguarding adult boards peer review. When I read this, I thought there must be a bullet point coming. There must be something killer coming, and it wasn't. So we've had the report. So Marianne, would you like to just expand? Is there anything that you'd like to inform us of that's not already in the report, really?
Yeah, we haven't done a PowerPoint presentation. You'll be delighted to know. I mean, the report speaks for itself. So I'll just tell you a little bit about why we wanted the report doing and what's happening next, really. And then we're happy to answer any questions. I'm mindful of the time. So the Safeguarding Adults Board in Calderdale was established in 2011, and it had an independent chair at that time. The chair's changed a few times over that period of time, but we've never actually had a peer review undertaken. So as an incoming chair, having discussed it with board members, we made a formal request that the Yorkshire and Humber Directors of Adult Services would come and do this challenge for us. So really to come and give us an external view on the work of the Safeguarding Adults Board and our ability to keep people safe in Calderdale. So really it was about benchmarking where we were, identifying priorities for us for the future so we could gaining our strength. And we specifically asked around 3 things. So one was around communicating and engaging with service users. The second was around the effectiveness of the board. And then the third one was about the visibility of our activity and you know, what value did we add really. So that was the reason for the ask. They came virtually for 3 days. It talks about who the members of the Peer Challenge team were. They use a standard methodology and they identified a number of strengths and areas for development, which you'll see in the report. I won't go through them all. You'll see that Burnt Bridges and the approach taken there obviously gets a number of notes. What we've done in terms of the areas for consideration for further development, we've discussed them as a board. We've had a vote really on the ones that we want to prioritise over the next 12 months. And we've highlighted kind of 4 key areas that we're going to really try and progress as a board. So we're working those into some smart action plans, having further more detailed discussions so that we can build that into our annual plan and work on that. So again, they're just things that are already mentioned in the areas for consideration, but particularly the ones that we're looking at really are considering the scope of the board and our relationship with other partnerships and their effectiveness in keeping people safe. So that's one of the areas that we're looking at. Looking at how we can get the board vision right down to the front line to give them that support during the pandemic and our recovery from COVID. Looking at how we can better engage with the community and voluntary sector. We do engage and they are represented on the board, but how we can do better in that area. Another one, which was seen as a strength actually, which was about gathering the lived experience of people in Calderdale, but not satisfied that that's a strength. That's something we want to develop further. So develop an approach to hear the voice of people with lived experience. So how can we really hear from people where things have either gone right or gone wrong and start to improve our services? So that will be our focus in our next business plan. But happy to take any questions if anybody's got anything specific they wanted to ask.
Thank you very much, Marianne. Councillor Barnes.
Thank you, Chair. I think for the purpose of the other committee members, we met earlier on in this week and had a quick chat about this, and we came up with some recommendations in relation to the idea of a peer review. And I think I'd leave it to the Chair to comment on those at the end of our session. But I think it was just important that councillors knew that. I think a couple of things. One, if I'm being really picky, I'm not sure that Scrutiny welcomed the Burnt Bridges review report, I think, on that one. But I think what I would like to say is, and in particular to Marianne, is that there's been a massive and marked improvement in relationships and between the board and this committee since her appointment. And I know at times we come across a little bit sometimes grumpy, sometimes a little bit maybe aggressive, assertive, but I think I would just like it put on record as to the significant changes that we've seen in that relationship over the period of time. I'm not going to make any specific comments on the peer review, but I just wanted that minuted. So thank you, Chair.
Yeah, no, thank you, Councillor Barnes. And as I say, it was a fairly useful discussion in relation to the peer review. We had I suppose I'll kick it off, and then I'm sure Councillor Barnes will help me along the way really on this one. And we probably it raised some issues in relation to when you actually conduct a peer review, and I sort of get why you did, but sometimes there's often a trigger and something that's gone wrong to instigate the peer review. So that was probably one of our first inquiries as to what made you do this, because as I said at the beginning, it sort of read it was very, very nice reading, and pat on the back and well done, which we congratulate you when you do things right, but it was almost missing something. It's almost yeah,
I mean, we did it not for a pat on the back, but really for a bit of a reality check. to somebody independently against, quite a straightforward framework. It's, other people will have the same methodology applied to them, so we can benchmark. But it was really, come in and tell us, what we are doing well in, but actually tell us the areas that we need to do better. And that was really what we wanted. It was, well, there was a lot of really positive stuff in it, which is nice, but that's not necessarily useful in terms of moving forward. So there wasn't any particular problem with the board. We have a really broad membership, but it's always really well attended at board meetings. Have some really good work goes on in our subgroups. So there's some fantastic work that goes on, but we just wanted somebody to come in and say, right, we've had a little bit of a poke around, and actually we really think these are areas that you need to build on, which is what they've done. And so that's what we will do with it.
Yeah, no, super. So we certainly get that, take that on board. I think the areas where it's raised more questions for us as councillors is actually peer reviews as a whole, and actually the involvement of members and the involvement, certainly, if a future one is carried out, it's about who sets the parameters out, and actually who's actually involved in the actual peer review itself. For instance, it would have been nice for us as councillors to have been involved in that peer review as an outside body. I think we're missing outside people sometimes. I know the council has done a peer review in relation to the planning department, and what they failed to do is actually ask the key members and actually the end users as well. So I think it's trying to learn from these moving forward. I'm going to bring some other people in, so I'm going to bring Ian in first, because you might all be able to help me out here.
Thank you. I was trying to see if I could go through scrutiny without actually speaking, but I thought it might be useful just to talk a little bit about the whole process of peer reviews. There's a national methodology around peer reviews, of which there's a particular tool that's around the safeguarding boards, but there are a series of tools that are formulated through the Local Government Association. Peer reviews are part of a wider approach called sector-led improvement, which is an attempt to try and improve services. Normally what you would have on a review team, and it wasn't possible this time, is an elected member from another authority, and they will look at this from a political member-led lens. And it was just unfortunate, I think, that we couldn't have that. Depending on the scale of the review, there usually are some opportunities to talk to elected members, and usually that's the interest, where you've got an elected member as a team member of the peer review. They will particularly want to develop that, and I've certainly been part of reviews when they ask to talk to Scrutiny, they'll ask to talk to the lead portfolio holder, which is probably a bit of the domain that we were kind of lacking, because we couldn't get an elected member from another authority. I know the review teams really welcome elected members volunteering to be part of peer reviews, but obviously you can't peer review your own area. But I would say that we would normally seek to get elected member perspectives. We just didn't do it on this occasion. We are required as a local authority, in terms of adult social care, the commitment we make is that we will have a peer review at least every 2 years to have that external view. But peer reviews don't replace your scrutiny function. And I think that's a really important bit here, is I think they can give Scrutiny a really helpful lens from the peer review perspective, but it gives you an opportunity to go further in your scrutiny.
Yeah, thanks Ian for that. Would we have any input in relation to the terms of reference, for instance, in future moving forward?
Normally what happens is the framework is set, and there are a set of domains by which the peer review comes in. Usually the commissioning organisation, which in this instance was the peer review, decide which of the domains are important to focus on. It is possible, if in future, that if Scrutiny had a view and we knew what that view was, we could try and accommodate that.
Cool. Yeah, no, thanks for that. And I think it's raised a few interesting questions, Marianne. So thank you for bringing it to us as well. So it's not actually you per se, but actually it's certainly actually is made us question some of the different things. Ian, yes.
Sorry, apologies, Chair. There's one more thing I was going to say, which is, and I think it's kind of echoing what Councillor Barnes has said. People who have been on the safeguarding board will know that for a number of years I was requesting and being quite challenging that I felt it would be timely to have a peer review. I think Marianne, as coming as independent chair, has been really open to seeking views, and I think open to challenge. And I think it's testament to her taking up the role that it's meant that we've been able to very quickly establish the peer review very early in a tenure as well, which I think really helps think then about where we want to take that tenure. So I really want to pay credit to Marianne for really picking up the mantle really quickly.
Yeah, no, totally agree. But I suppose the question is, in hindsight, do you think this should have been carried out prior to your arrival? I guess in some ways that's the biggest question I guess I'm sort of thinking about, and it's a question we can't. Hindsight's a wonderful thing, and we can't go back, and we've done it, and that's great. But I think as an independent chair, you've moved. I would say the organisation, but you've moved it forward in a long way. I think possibly there were some issues prior to your arrival, but equally, I think. I'll bring in Councillor Kingston, and then I'll bring back in Councillor Barnes.
Just reading this, I was impressed by it. And what I appreciated was that you've subjected yourself to scrutiny by people that really know what the remit of your role is, what it is that you're meant to be doing. Because it felt like that they've been able to go much further than I feel that I could go in a scrutiny board meeting like this, because they know much more what it is that you're supposed to be doing. And it just looked, to me, very thorough and a lot more detailed than what we would do in these meetings. So I was impressed by that. And then my only question from it was, what are you going to do to implement the recommendations? What's your action plan for doing that? What's the timelines that are involved? I presume that you've planned meetings, that you're going to delegate tasks to specific people to identify the way that these recommendations can be implemented, and that you're going to set targets for yourselves around that. I just want to know what's your action plan and your timeline around doing.
Yeah, absolutely right. And let me say, it's not just me that's opened myself up to scrutiny, it's the board itself. So, the other people, Ian, Julia, the members of the board across the board have opened themselves up to scrutiny, not just me. But thank you for that feedback. Yes, we've already discussed the report at our board meeting. We've identified of the areas for consideration, areas for development. We've identified the top sort of 4 or 5 that we hope over the next 12 months we can really make some headway with. They've all been, an individual has offered, or a group of people have offered to lead on each one of those. So, for example, the one around community and voluntary sector, I've got a meeting tomorrow with a few other people where we're going to start to unpick that a little bit and start to develop a bit of a smart action plan, if that makes sense to you. It will probably look like an Excel spreadsheet with a RAG rating. But yeah, we will build a development plan for us as a board that we will work through over the next business year. That's not to say that other things might drop in during the course of the year as we make progress. But yeah, that's exactly how we will address this.
Thank you, Marianne. Councillor Barnes.
Thank you, Chair. First, I'd like to apologise to Ian Baines for forcing him to speak tonight. It's a hard life, isn't it? Secondly, I think the point about involving scrutiny is important, but it's also the fact that scrutiny need to know that the peer reviews are going ahead in the first place. If the first thing we know about a peer review is when it's hitting our inboxes with a report, it's a bit late in the day for Scrutiny to be able to make any form of comment. And I think these recommendations relate across to peer reviews across the piece. It's not relating to this one. It's we just think that the involvement of the relevant committee chair, committee deputy chair, and also potential, as in, let's say, in planning, would people who have put planning appeals in would actually add to the review and improve the service. And that's what we're all about here. So thank you. And once again, apologies, Ian.
Yeah, and I think you've hit the nail on the head. Thank you, Councillor Barnes. And that was the element, Marianne, is actually made us think ourselves. So actually what you've done is help us to think as a scrutiny board as to how can we improve ourselves as well. I think that, so it's brilliant. So yeah, fantastic report. I didn't expect anything less from you in charge of this adult safeguarding board, but it's nice to get clarification and ratification that actually you are doing some wonderful work and moving in the right direction. So very, very much thank you for attending. Thank you, Julia, also for attending and taking all the questions. I think we've been fairly okay with you. Hopefully you're not going to go away upset. So then we'll catch up soon, I'm sure. So thank you for that. Which takes us on to the item number 7, our final item, which is the work programme. It has been circulated. We had a meeting earlier this week to make some amendments. Mike, would you like to very, very briefly just update us?
Very briefly, Chair, Councillor Bradburn and Councillor Barnes met with Ian Baines and colleagues, and we are proposing to take the commissioning item in bite-sized chunks and focus on supported living and extra care at the next meeting, and then pick up on other issues relating to commissioning during the new next municipal year. We had a good discussion about the neurodiversity item, and we are going to work, I'm just going to work with Rona, who you met earlier, and with Swift, to put together an item that will allow the Scrutiny Board to inform the future direction and commissioning of services for people affected by neurodiversity and autism in particular. So that's, rather than looking back on the item we had probably nearly 2.5 years ago, that's, well, I'm sure we make reference back to it, but that's looking forward on that issue. Those are 2 fairly meaty items, and we're suggesting that the dementia item that we've had on actually for a while, we'll give some more thought to and do in the summer. And I think that's all I need to say, Chair, on that one. Only to remind you, you've only got a couple of meetings left for the municipal year, so there's not much time to build in everything we need to do. Thank you.
As always, I think it's been a really good year, a good year of discussion. So I'm actually proud of what we've done and achieved as a board, as a whole collective board. So yeah, well done, board members, on that one. Continue the questioning and the real nice questions actually. So I think that concludes the business of the day. So thank you everyone for attending, especially Debs and Ian. Very much appreciated, and Sean, of course, not forgetting Sean, and your inputs, and of course members' input is extremely valuable. I hope you enjoyed the rest of the evening, and have a nice weekend as well. So